Classification systems abound in the neurosurgical literature. The classification systems themselves, however, have not been systematically classified, and limited guidance is available informing the development of such systems. Some classification systems are purely qualitative, others have quantitative features. Some are purely descriptive, others are explicitly prescriptive in informing treatment, and yet others are predictive or prognostic. In this chapter, we present an initial effort to compile and organize the neurosurgical classification systems in contemporary use, and to classify them according to type, as well as according to several criteria pertaining to their practical utility. We address features such as consistency, inter-rater reliability, internal validity, external validation, strength of evidence, and generalizability. Metaclassification, the classification of classification systems, shares some features with systematic review and meta-analysis. However, while there are established guidelines for systematic review and meta-analysis, such as those published by the Cochrane and Prisma consortia, there are none for metaclassification. In a process informed by the Prisma Systematic Review Guidelines, we searched the entire corpus of Yeomans and Wynn Neurological Surgery 8th edition prior to publication of this edition for classification systems, using a set of keywords intended to reflect the classification process. Our search space was the full text of the current edition. This comprehensive and collaboratively written and edited textbook of neurosurgery was considered to represent international expert opinion across neurosurgical subspecialties as of 2021. The search process yielded 2,758 systems using the word classification, 1,657 using the word staging, 4,234 using grading, 1,792 using score, and 1,144 using the term scale. After removal of duplicates, 1,347 unique classification systems were identified. Individual review of all of these was used to assess for clinical relevance to modern neurosurgery, yielding 488 clinically relevant neurosurgical classification systems in the current edition. We then developed a classification system for these classification systems. The metaclassification system is based on the answers to three questions. First, is the system purely descriptive? All classification systems are descriptive by definition. Some, particularly those used to describe anatomic and pathological structures, are purely descriptive by design. Others use descriptive classes as a precursor to guiding therapy or prognosis. Examples of purely descriptive classification systems include the WHO classification of tumors of the central nervous system, the Modified Rankin Scale for Neurologic Disability, and the British Medical Research Council grading system for muscle strength, among many others. These are examples of Type 1 classification systems. Second, is the system prescriptive? Some clinical classification systems are designed to guide clinical decision-making. The Thoracolumbar Injury Classification and Severity Scale, TLIX, and the Spine Injury Neoplastic Scale, SINS, are designed to evaluate the presence and degree of spinal instability in order to assess the need for surgical stabilization. These are examples of Type 2A classification systems. Third, is the system predictive? Some clinical classifications guide prognosis. The Karnofsky Performance Scale in patients with cancer and the Hunt and Hess scale in patients with aneurysmal subarachnoid hemorrhage are both predictive of mortality. These are examples of Type 2B classification systems. Type 3 classification systems are comprehensive in the sense that they are descriptive, prescriptive, and predictive. Of the 488 neurosurgical classification systems discussed in this edition, 301 or 62% are purely descriptive, 36, 7%, are prescriptive, 120, 25%, are prognostic, and 31, 6%, are comprehensive, descriptive, predictive, and prognostic. A fourth question is also important. What is the strength of the evidence on which the system is based? In practice, this question is more difficult to answer as relevant data are not always present or complete concurrent with the establishment of a classification system, and more data will almost inevitably emerge with time. The Simpson grade of meningioma resection, for example, is a type 3 classification system in our scheme, yet it is supported by limited and old case series evidence, the lowest subdivision of level 2 evidence. By contrast, the Glasgow Coma Scale, also a type 3 classification system, is supported by extensive evidence confirming its utility in guiding intervention and prognosis in the decades since it was first described. Both of these classification systems have practical utility, and both have been subject to extensive criticism in the neurosurgical literature. Both belong to type 3 in our classification of classification systems, and yet they differ markedly with respect to the strength of evidence on which they are based and the evidence that has emerged since they were initially described. We present the complete list of 488 classification systems, cross-referenced into the chapters of the current edition and annotated with bibliographic information and according to classification type. The entire annotated list, together with key citations, is provided with the full text of this chapter.